You can see the video, right?
Yes.
Yeah, we see it.
These can be scary, but don't panic. People with diabetes can live long, healthy lives. Sure, let's go over some basics. This is diabetes. It's simple. When we eat, food travels to the stomach. Food is made up of 3 basic nutrients: carbohydrates, proteins, and fats. During digestion, carbohydrates are broken down into sugar, otherwise known as glucose. Here's a quick fact. Carbohydrates include foods such as bread, rice, pasta, potatoes, fruit, milk, and yogurt. In a normal digestive process, sugar travels from the stomach through the bloodstream to your body's muscle and fat cells. However, sugar can't enter these cells without the help of a special hormone called insulin, which is produced by the pancreas. Insulin acts like a key, unlocking the doors to the muscle and fat cells and allowing the sugar to enter. The cells then use this sugar as fuel to provide energy for the body. When this process is functioning properly, sugar entering the bloodstream from the stomach is able to exit the bloodstream at the muscle and fat cells. In this manner, the body is able to regulate the concentration of sugar in the bloodstream. Now let's see what happens in a person with diabetes. Sugar enters the bloodstream, but one of 2 things happens. Either the pancreas does not produce a sufficient quantity of insulin to match the sugar entering the bloodstream, or the body cells do not respond to the insulin that the body is producing. In both cases, the result is the same. Cell doors remain closed, causing sugar to get backed up in the bloodstream. As a result, blood sugar levels rise. This creates several problems. Because sugars are not able to enter your body's cells, your body is not getting the fuel it needs. As a result, you may feel tired or fatigued. Your body may try to dilute the excess sugar in the bloodstream by pulling fluid out of your cells. This can leave you feeling dehydrated and thirsty. Most importantly, over time, exposure to high blood sugar levels can cause damage to vital organs connected to the bloodstream, such as your eyes, kidneys, nerves, and heart. If not controlled properly, diabetes can lead to serious complications, such as blindness, amputation, kidney failure, heart attack, and stroke. In order to avoid these complications, people with diabetes must take steps to keep their blood sugar levels in a normal range. One way to do this is through diet. By reducing the amount of carbohydrates you eat in a single meal or snack, you can regulate the amount of sugar entering the bloodstream and prevent your body's insulin supply from becoming overwhelmed. This may mean limiting high sugar foods such as cake, pie, candy, and soda. You know which ones. Another way to regulate blood sugar is through exercise. Physical activity makes your body's muscle and fat cells more receptive to insulin. In other words, those muscle and fat cells that wouldn't open before, now they will. Finally, your doctor may prescribe oral medications to increase your supply of insulin, regulate the amount of sugar entering the bloodstream, or make your body's cells more receptive to the insulin your body is producing. In some cases, insulin shots may also be necessary. Okay, let's review. We've talked about what diabetes is, a condition where either the body does not produce enough insulin, or the body cells are not receptive to the insulin being produced. We've seen what complications can arise from it, such as fatigue, dehydration, and damage to vital organs.
All right, so that's diabetes short and sweet. Let's go to chapter 64. So there are 2 types of diabetes. We have type 1, type 2. Type 1 is the type wherein there is absolute no insulin produced by the body. It's usually autoimmune. We'll see a table comparing the 2 side by side shortly. And type 2 is a condition wherein you don't have enough insulin and or your body is not receptive to your own insulin. That's what we call insulin resistance. Risk factors for diabetes. We have several. We have obesity. It's also hereditary in the case of type 1. Um, no, they're not listed here. But if you remember chapter 36, diabetes, hypertension, heart disease share the same risk factors. Obesity is number one. We also have a high cholesterol diet. We have something called metabolic syndrome, which we'll talk about later, and various others. So let's compare type 1 and type 2 first. Um, type 1 can be autoimmune. Type 2, you can develop this. Number one factor again is obesity, or what we call metabolic syndrome. Metabolic syndrome is characterized by hypertension, high cholesterol, as well as a abdominal obesity, a waist size of 40 inches or bigger. You fall under metabolic syndrome. Metabolic syndrome is not diabetes, but it does increase your risk factor for type 2 diabetes. There are other conditions resulting in hyperglycemia. There's also something called gestational diabetes. Here, used to be gestational diabetes resolves after delivery of the baby, meaning the patient is only diabetic because of the pregnancy. However, lately, more women go on to develop type 2 diabetes even after delivery of the baby, unlike before where it went away with the pregnancy. These other conditions, these are not diabetes per se. However, they do increase blood sugar in the blood. They're usually related to the adrenal problems, such as here, for instance, Cushing's and hyperthyroidism or hyperaldosteronism. These are short-term, meaning these are not technically diabetes, but the patient does have signs and symptoms of diabetes, which are signs and symptoms of hyperglycemia. But technically we have three. So we have type 1, type 2, and gestational diabetes. So let's review how our body produces sugar. So we are made up of sugar. Our fats and proteins can be broken down and converted to sugar. We also have a emergency storage in the liver called glycogen. That is our emergency source of sugar. So during starvation conditions, let's say you're stuck in a train, can't get anything to eat, or you're out somewhere, you have no access to food. So you'll be kept alive with glycogen until it of course is exhausted. Then your body will go after other sources of glucose, such as your fats and your proteins. Glucagon is the emergency hormone secreted by the same pancreas. So your pancreas produces both insulin, which lowers blood sugar, and glucagon, which will raise blood sugar. It just depends on what you need. I won't go into the details here. Long story short, how do we develop hyperglycemia in diabetes? All right, so we know our blood sugar is between 60 and 150. Well, the normal is 110. However, in order for us to stay alive, especially when we are fasting, we can maintain it no problem. We have counter-regulatory mechanisms. As I already mentioned, we're pretty much made of sugar. So we have glycogen, and then fat, and then protein. Now, remember, in diabetes, these counter-regulatory mechanisms, these mechanisms by which we can produce sugar in the absence of food, or in the case of diabetics, is the absence of insulin, because we need insulin in order for the cells to access sugar. That means we cannot use glucose unless there is insulin. So therefore, we need insulin in order to use glucose. In the absence of insulin or in the presence of insulin sensitivity, insulin resistance, sorry, we cannot use glucose. So what happens is sugar will end up in the bloodstream, but look at what happens. Okay, so let's say type 1 or even type 2. So type 1, no insulin. Type 2, no, not enough insulin. Plus, there is insulin resistance. Okay, so what will happen? So just like on the video, so let's say these are glucose molecules. All right, and these are your cells. And the three signs of hypoglycemia are polydipsia, polyphagia, and polyuria. This is excessive thirst, excessive hunger, excessive urination. Now, how do these appear? All right, so there is no insulin. We said we need insulin in order for these glucose molecules to enter the cell. We don't have it in type 1. We don't have enough in type 2. Plus, if we have insulin, the cells do not respond to insulin. So, your cells become hungry as a result. So they send a signal to your brain, hey, I'm hungry. The body has no idea it has no insulin, or the body has not enough insulin, or there is insulin resistance. All the brain knows is the cells are hungry. So it will command pancreas to produce glucagon. Glucagon is released, breaks down glycogen. That adds to the glucose. So now we have more glucose. But was the problem the lack of glucose? Was that the problem?
No.
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 The problem was no insulin, or there is not enough insulin, or there is insulin resistance. These were the problem. It wasn't the lack of glucose, but the body has no idea that that was the problem. All the brain knows again that the cells are asking for glucose. We're hungry. So this one is exhausted. The sugar by this point is already over 110. So let's say 150 at this point. It'll go higher next because now we go after fat. This is now Keto Genesis. So fat is also turned into glucose. Okay, so now we have more glucose from fat now. So it increases now. Does this finally solve the problem?
No, the body keeps making it worse.
Right, so this is now getting worse. But does the body know that?
No.
No. Patient cells still say, hey, where's the sugar? So the brain now commands gluconeogenesis. So this is now protein. So now we go after protein. Again, turning that into glucose, adding here. Now, please tell me this solves the problem. Yes?
No.
No, the problem got worse and worse. Now we have nowhere to put this glucose now. So this will increase the osmolarity of point, the patient's blood sugar is now way over 250. So this will increase the osmotic pressure of plasma, because now you have a lot of
Professor,
Okay, let me try to switch. How about now?
seems good for now.
So now the osmotic pressure rises because now you have more solutes compared to solvent. So the blood is now so thick. To balance, osmosis comes in, and osmosis says water must move from an area of lesser concentration to an area of greater concentration. So therefore, it will draw water out from the cells and the interstitial spaces. Cells therefore get dehydrated, leading to the first P, polydipsia. So patient goes thirsty, patient drinks water, doesn't make a difference because now this mechanism here, these two are already running. So this will only get the sugar higher and higher. Until we resolve the hyperglycemia, these will continue to appear. So once the the sugar's high, and then it now dehydrates the cell. Of course, the patient is also very hungry, so there will be increased thirst. Hunger continues because they cannot get to the glucose that's overflowing already in the bloodstream. This increased blood volume that results from osmosis is now going to lead to osmotic diuresis because blood volume increases. The kidneys see it. Of course, the kidneys will get rid of the excess fluid, leading to polyuria. So it becomes the patient is caught now in this cycle, which will not end until the patient goes into shock and then dies. So the cause of death really here is dehydration, not technically diabetes, at least not in the acute complication. So the two acute complications of diabetes will be discussed in 205, 2 semesters from now. But this is basically what happens. Now, how do diabetes type 1 and 2 damage vital organs? So these are now the chronic complications. Now imagine your capillaries, arteries, veins having this thick of a blood. When they go into microcirculation, such as the vessels supplying your eyes, those microscopic nephrons also need blood flow. Your coronary arteries and the capillaries supplying your myocardium, those in your brain as well. So you have capillaries and arteries in your vein. Your nerves also need blood supply. So all these microscopic circulations, if you run really thick blood there, do they perfuse the organs well? Your eyes, your heart, your brain, your kidneys?
No.
Tract? No, there will be very poor circulation. Multiply that by several months, several years, several decades. What will happen to those organs? If you continuously deprive them of proper blood flow because you have uncontrolled diabetes.
They start to fail.
All right, so that's why those are now the chronic complications of diabetes. So let's go back to diabetes. So these are the story now. We talked about glycogenesis, glycogenolysis, ketogenesis, and gluconeogenesis. So that's all that. This one is nice to know if you're interested in looking at the responses to insufficient insulin. That's good. Here are the 3 P's we just discussed, why they appear. We'll discuss ketone bodies later, but this is part of the two hyperglycemic acute complications. For this semester, we'll only be talking about hypoglycemia. We'll discuss the other two in another semester. So the dehydration that results from the severe hyperglycemia will lead to hemoconcentration, of course, and that will lead to hypovolemia, the polyuria, and of course the patient goes into shock. There are three acute complications. As I said, we will discuss these two semesters from now. We'll only concentrate on hypoglycemia, which is toward the end of the chapter. Let's talk about chronic complications. So the video, as well as our discussion, mentioned these are the other risk factors that which will make your condition worse. Meaning this will add to the damage to your organs on top of diabetes. So let's start with macrovascular. There are two macrovascular complications affecting the brain, leading to stroke, and cardiovascular disease, leading to heart attacks or heart failure. So this is macro, cardiovascular, and cerebrovascular disease. So again, heart attack and stroke. Microvascular complications, let's begin with the eye. Eye damage resulting from diabetes is called diabetic retinopathy. So this is the growth of new retinal blood vessels. However, these are not normal blood vessels. So this is in response to the poor circulation because you have sluggish blood flow. You have sludging. Okay, so imagine circulating Slurpee through your bloodstream, okay, in your vessels. You put Slurpee in there because that's how thick your blood gets. And so in response, the eye grows new blood vessels. However, these new blood vessels are not normal. They are thin, fragile, bleed easily. And that's how you lose vision. As far as this is now for the nerves. So all our body have nerves, right? So nerves also need blood flow. So when you have less blood flow to these microscopic nerves, of course, that will now lead to all sorts of neuropathy. So you can have neuropathy in your extremities, particularly the feet. So now no more sensation there. So that's when you start getting diabetic ulcers because now you cannot feel at the bottom of your feet. So it's not, so when you walk, it's like wearing shoes without shoes. So when you injure your foot, you cannot feel it because it's like the shoe. Okay, so the shoe is not part of you. So whenever you step, you're stepping on glass, a piece of nail, thumbtacks. So your feet are now prone to injury. You cannot feel the pain. So therefore, you tend to neglect what you can't feel. And then that's how diabetic ulcers now begin. I'm not testing the features of diabetic neuropathy. We're not going into that detail. However, the patient, of course, will feel these. So they have no sensation. If they do, they have pain. And the pain here is described as burning, tingling sensations. And this is constant. So the patient will be quite uncomfortable. And this type of pain, of course, will be treated with anti-seizure medications, gabapentin specifically. It will be mentioned later under interventions. Next we have autonomic neuropathy. This one is now nerve supply to the GI tract, particularly your stomach. Patients with diabetes may develop gastroparesis. This is now nerve damage to the stomach. As a result, the stomach does not empty at the correct time. Usually, our stomach empties 1 to 2 hours after a meal. So the food sits in the stomach for 1 to 2 hours. While it's there, it's being turned into liquid, right? So our gastrin, pepsin turns whatever we eat into liquid, and then 1 to 2 hours later, it enters the duodenum for absorption. So all the liquid food is now absorbed in the intestines, nourishing the body, and of course that will increase blood sugar at that time. So that's why your sugar starts rising about 1 to 2 hours after eating, because it's not really absorbed. Majority is not absorbed until it reaches the small intestine. We start absorption in the mouth and in the stomach, but that's only minor. A majority of the food is and the glucose is absorbed in the small intestine. And then finally, when they enter the colon, then it's just reabsorbing water. That's why our stool is dry and solid by the time it comes out. So this could be a complication because our insulin is designed to peak at about 1 to 2 hours after administration. So perfect timing, when the stomach empties, sugar rises 1 to 2 hours later, which is about the same time when your insulin peaks. So therefore, you don't experience hypoglycemia, because by the time the insulin peaks, meaning that's the time of highest drug action, there's sugar there that is also high, so it drops the sugar. Perfect timing. Now imagine what happens if the patient has gastroparesis. So the stomach doesn't empty until 1 to 2 hours later than normal. So by the time insulin peaks, what is the patient's blood sugar level? Is it high or low?
Wouldn't it be low?
It'll be low because
There's nothing there.
the stomach hasn't emptied yet. The sugar hasn't reached the small intestine yet. So that could be one cause of hypoglycemia, which is dangerous. Acute complications are life-threatening. So the DKA, HHS, and hypoglycemia are all life-threatening, especially hypoglycemia, because the symptom in hypoglycemia, especially for these long-term diabetics, they may not have adrenergic symptoms anymore over time. So they won't know, they'll just pass out. And then especially if they live alone or nobody catches when it happens, they'll never wake up again. So this will be listed later as one of the causes of our hypoglycemia. It can also affect the bladder. So all sorts of problems can result with nerve damage. So here you also have urinary problems. So your bladder will not completely empty, which the longer urine sits, then that leads to UTI, plus the fact that the sugar also leaks in the urine. Your urine is very sweet. Bacteria growth will be promoted, leading to more likelihood of a UTI. Then later, the UTI goes up into your kidneys. You have pyelonephritis, kidney damage results, etc., etc.
Professor, I have a question.
Yes, sir.
Before, when you were doing that picture, you had said that the patient will have polyuria, so they're going to be urinating a lot.
Right. Oh, I didn't finish that part. Okay, so the kidneys, I think I mentioned it. So the kidneys see the increased blood volume, so therefore the kidneys, of course, will get rid of it.
Okay, so then
that leads to the polyuria, meaning it will be constant because the sugar still remains high, so it will continually draw water from the cells, dehydrating the cells, but then also getting rid of the water. So that's how the patient gets dehydrated, is from osmotic diuresis.
Okay, and at the same time, they cannot have enough urine emptying while that's happening, and that's what causes the problems in the kidneys.
No, these are two different. Remember, these are what we're talking about right now are chronic complications.
Oh, okay. All right, I
Yeah.
got you.
So what I described earlier was more of an acute episode.
Okay, now it makes sense. Thank you.
Okay. So next is diabetic nephropathy. So this is now damage to the kidneys. Used to be, I think I mentioned this in hypertension, that used to be hypertension was the #1 cause of end-stage kidney disease. Now it has been overtaken by diabetes. The cause in diabetes is called acute tubular necrosis, meaning the nephrons have two components, right? They have the glomerulus and there's the tubular compartment, the loop of Henle. The tubular component dies because of lack of blood flow due to the sludging, okay, the chronic hyperglycemia. Those damage the kidneys, the nephrons, little by little, and then multiply that by number of years, months, and then the kidney eventually is more dead than functional. And of course, the patient now has ESKD and has to depend on dialysis pending a transplant. And of course, once the diabetes damages the kidney, blood pressure sets in because now you have no kidneys, along with all other problems related to chronic kidney disease. You'll discuss CKD and ESKD dialysis next semester. Probably the most serious among all these is sexual dysfunction. So there will be erectile dysfunction here, which is most life-threatening compared to all the complications, right? And in some patients, the patient may have cognitive dysfunction, also related to lack of blood flow to the brain. Here's the side-by-side comparison between the two. Former names, because these are literally former names. They're no longer true. When I went to school, yes, they were true. Type 1 diabetes used to affect only young people. They were the only one that developed ketoacidosis, and they were the only ones that were treated with insulin. Now, even young kids can develop type 2 diabetes. Type 2 diabetes can develop DKA now. Type 2 diabetes is treated with insulin now. So we can say diabetes evolved over the years as more and more cases develop. Younger people are developing diabetes now. So it's all related with advances in technology and everything else we're doing. Or everything else we're doing less stuff, like exercise, for instance. Both, both can have hyperglycemia as well as hypoglycemia. In type 1 diabetes, the symptoms usually occur suddenly.
Walk.
In
Store.
In fact, the patients with type 1 diabetes, the first time they are diagnosed with disorder, maybe during an acute episode of DKA, meaning they had no idea they were diabetic, and then when the symptoms come, it's already a hypoglycemic emergency. In the type 2 diabetes, it develops longer, over several months to several years before the patient develops the symptoms. So it's so subtle that they just think, especially if it's like, say, summer, okay, they just blame the symptoms on summer, the heat, especially the polydipsia, polyphagia, and the polyuria. Okay. They may blame it on that, or let's say they already have eye damage, for instance, the chronic complications. They just blame it on age, okay, not knowing that they actually are diabetic. We don't know what causes type 2. We do know that type 1 is more autoimmune, meaning there is auto-destruction of the beta cells. This is the part of your pancreas that produces insulin. And this one is insulin resistance, typically because the profile of a type 2 diabetic is usually obese. The increase in the number of adipose tissue makes the remaining muscle cells less sensitive to insulin. And please read the rest. The important part really are the first few rows. It's not really testable. The rest of these are not really testable. I mentioned metabolic syndrome earlier. So this is metabolic syndrome. I mentioned abdominal obesity, 40 inch or higher waist size, hypertension, hypoglycemia.
Professor, you're breaking out.
I was saying this is metabolic syndrome, and I already mentioned these characteristics earlier. And of course, once you have high glucose, the body always converts glucose into fat, and that fat can be stored in the abdomen or in the blood vessels. So you can say also diabetes contributes to atherosclerosis. And you already know about atherosclerosis under hypertension. Let's go to the diagnostic testing. I'm not testing table 64-5. I'm testing the test results. This one, of course, is prevention. So you know the risk factors. So eat healthy, lose weight, manage blood pressure, exercise, and all that good stuff. Eat right. So how do we make a diagnosis of diabetes? The doctor will have to make a clinical diagnosis. The tests ordered there are 4. So let's start with chart 64-1. You know what? Let's go to the next one. Let's go table 64-6. So you can disregard 64-1 because the complete list is really in 64-6, table 64-6. So a patient is diabetic when any one of these tests are positive. The number one is A1C. A1C is most reliable because it'll be explained in the paragraph right here. A1C is glycosylated hemoglobin. When sugar is present in the bloodstream, they leave a stain on the hemoglobin. So when they ride red blood cells, they leave a stain. So therefore, since red blood cells live for about 120 days, the percentage of red blood cells carrying a glucose stain called glycosylated hemoglobin is a prime diagnostic test to see what is your average blood sugar in any given day. So if your A1C, if the percentage of your red blood cells is more than 6.5%, that means you are diabetic. I'll show you a table later showing you the average blood sugar depending on the A1C reading. So since A1C gives you 120 days worth of data, it's more reliable compared to the other 3. The other 3 tests are still diagnostic of diabetes, but the other tests can be cheated or can be affected. For instance, a fasting blood glucose greater than or equal to 126. This means you're also diabetic. However, if the patient, for instance, fasts longer than usual, meaning yesterday before the test, they did not eat at all, or if anything, they just eat maybe a few pieces of cabbage, for instance, okay, or and a lot of water. So therefore, that will affect your fasting blood glucose the next day. Or if you do a 2-hour blood glucose, this is also called the glucose tolerance test, or this is also called a postprandial glucose, meaning you'll be told to go eat lunch, and then 2 hours later you come back and we check your sugar. So typically a normal person after 2 hours after a meal drops the blood sugar if they have a normally functioning pancreas. A diabetic will be unable to drop that blood glucose for obvious reasons. They have type 1, no insulin, or type 2, not enough insulin, or they have insulin resistance. So of course, the 2-hour blood glucose will be equal to or greater than 200 if you are diabetic. Or the last one, this is a random. The 2-hour blood glucose can also be affected. So let's say I only ate a very light lunch. I only ate a piece of toast, for instance, or maybe a piece of fruit. 2 hours later, of course, my sugar may not be equal to or greater than 200. Or let's say random. Random blood glucose is we just take it, anytime. Let's do one now. If your random blood glucose is greater than 200, then you will be diabetic. Of course, that is also affected by several factors. What if I just ate 20 minutes ago? Or what if I just had a candy bar right before you tested me? Okay, so in this instance, that really makes A1C the most reliable, because this is 3 months worth. You can't cheat this. You understand? So unlike the other 3 tests, which are affected by other factors, this one, you have to be affecting this for a whole 120 days, which is hard to do. Okay, so this one is more reliable because it gives you more long-term data rather than just overnight or a few days ago. And here's the explanation for A1C. Please read that on your own. Here is what I mean. I'm not testing this, but just to give you an idea. Look at this. If your A1C is 6, that means your mean blood glucose is about 126. Look at it when it's 12, 298, meaning this is your mean, meaning mean is not average, it's about the median, right, between the lowest and the highest. That's pretty high. 298, or even this one, 126. Let's now go to interventions. So with type 1 diabetes, it's easy. The patient only gets insulin because they have no insulin. That's it. No other drug treatment is given, only insulin. Of course, the other treatments are non-pharmacologic, which is diet and exercise. The same thing for type 2 diabetes. However, with type 2, you have other options besides insulin, diet, and exercise. You also have oral hypoglycemic drugs, which were mentioned. There were 3 mentioned in the video. One was to affect the GI tract, meaning you'll be given drugs to slow down the absorption of glucose in the GI tract. Another class of drugs may be used to decrease production of glucose from the liver. Glycogen prevents glycogen from being converted to glucose. Another possibility is to force your pancreas to make more insulin. Or number 4, we can make your muscles more sensitive to insulin. Okay, so the type 2 diabetes has more treatment options compared to type 1. We'll discuss all those one by one. So drug therapy, let's start with type 2 diabetes first. So chart 64-2 are all for type 2 diabetes. They do not work for type 1 because again, what's the only treatment for type 1? What's the only drug treatment?
Insulin. Insulin.
That's it. They can't get anything else because their pancreas doesn't make insulin. However, type 2, remember, they still have some insulin. The insulin just doesn't work all the time. Either they don't have enough or they are resistant to their own insulin. So the first group of drugs is sulfonylureas. Look at the function. So this will help you remember because there's a lot of drugs. There's no way around this. All of these drugs listed in this chart are testable because they're all out in the market. They're all out in clinical. So sulfonylureas work by triggering the release of insulin, meaning it stimulates the pancreas to produce insulin. So that's why its side effect is hypoglycemia. The danger here is if you give insulin with sulfonylurea, because now you have two insulins pretty much. Exogenous insulin from the vial plus the patient's own insulin. The problem here is we don't know how much insulin the body will produce. That's what makes it dangerous when compared, when given with insulin. So typically, the warning on the drug label here is do not use glipizide with insulin. It is because it's just not safe. I'm not saying they won't. Some doctors prescribe both, but just know that the chances of hypoglycemia is greater. Another thing I want you to remember in this chart is not all of these drugs will cause hypoglycemia because they don't work the same way. Of course, this one will cause hypoglycemia because it triggers insulin production. And the number one complication or side effect of insulin is, of course, hypoglycemia. Please read the rest of the side effects. I can pick up any of these for a test question. They're very easy to make and they're very easy to reference because it's right here, chart 64-2. You probably have at least 4 questions on the test on this chart alone. Next group are biguanides. There's only one here, metformin or glucophage. How does this drug work? So it acts on the liver and also on the GI tract and also on the muscles. So 3 actions. One is inhibits glycogen from being broken down. Next is it decreases GI absorption of sugar. And then finally increases sensitivity in the muscle cells. As you can see, there is no side effect of hypoglycemia listed here because that's not how the drug works. The drug does not stimulate the production of insulin. It only helps the type 2 diabetic use up their insulin more. Plus, at the same time, decreases intestinal absorption of glucose, but does not prevent it. It only slows down absorption. So it's seldom, if any, hypoglycemia occurs. However, it is quite harmful to the kidneys. That's why when you receive a test using another nephrotoxic agent, such as an IV dye, that's too many nephrotoxic agents at one time. Again, the drug itself is nephrotoxic. If you add another nephrotoxic agent to the mix, you'll be guaranteed for kidney damage. So therefore, you can only have one or the other. So if you're taking metformin and you have to have a test using a dye, you have to give up one. We can't give up the test because we need the test for some reason. So you have to give up metformin for 2 days. So no metformin for 2 days. because it's nephrotoxic, plus you just received another nephrotoxic agent. So that's your number one consideration. Remember that cardiac catheterization also involves the use of contrast agent, IV dye. So not only for CAT scans, but also cardiac catheterization or any test or procedure that uses an IV dye. Here are some of your other side effects. Next is TZDs or Thiazolidinediones. These guys decrease liver production and also improve sensitivity, similar to metformin, without the kidney damage. This one also has no hypoglycemia listed here, but we do have a black box warning here for heart failure. So they all end in the same sounding names. They end in litosones. Pioglitazone, rosiglitazone. They're easy to remember. TZDs again have a black box warning for heart disease, for people with heart disease. And it's also known to cause osteoporosis and weight gain and peripheral edema. Of course, that will be symptomatic of heart failure already. So that's why your teaching here is teaching them signs of heart failure. Next drug, acarbose. The brand name is Precose. There's only one action here. This will slow down GI absorption again of glucose in the GI tract. Here's a warning. So if the patient doesn't eat, the drug is also not given. Okay, so the patient has to eat. Makes sense because its action is to delay digestion of glucose. So therefore, the patient has to be eating for the drug to work. You'll see this drug again in obesity because this is a drug used after gastric bypass surgery because the patient has a smaller stomach and they're prone to a complication called dumping syndrome. This will help with the symptoms of dumping syndrome. The patient doesn't have diabetes, but they use the drug for that purpose. Like I said, you'll discuss dumping syndrome later. Next semester, I think. Then we have dulaglutide or Trulicity. You've seen the commercial probably on TV. So this thing is a injection. However, it is not insulin. Okay, it's a subcutaneous insulin. However, I mean subcutaneous injection, but it is not insulin. It works with insulin. Okay, but again, don't be confused that it's injectable like insulin, but it is not insulin. So this one works by inhibiting glucagon, so therefore no glucose breakdown from the liver, and also delays gastric emptying. Now, this one, because of the action, this one has hypoglycemia. So this is the second one. First one was sulfonylurea. Now we have dulaglutide. So this is again Trulicity. So this causes hypoglycemia, and because it's an injection, so watch the injection sites. Oh, here it is again, pancreatitis. So because of its action, because it inhibits glucagon, it can damage the pancreas. So hypoglycemia and pancreatitis. The next drug is Victoza, I think it is. Yes. No, not yet. But this drug also causes pancreatitis and hypoglycemia. So first one was dulaglutide. Now we have sitagliptin. So for this group here, incretin mimetics, I'm only testing dulaglutide because that's the most commonly used here in America. And then for DPP4s, we only use Januvia. sitagliptin. And just like dulaglutide, it causes hypoglycemia and pancreatitis. They have similar actions. See, decreased liver production of glucose as well as decreased glucagon secretion. So identical to incretin mimetics. Then we have, we'll skip this one. I didn't highlight this one. We'll skip the amylin analogs. And next one is, yeah, I'm missing Victosa. Where is Victosa? Oh, Victosa is liraglutide.
Hello, Professor. The one you highlighted. Go back.
Say what?
Right below something that you highlighted that was in yellow.
Okay,
What goes down?
And liraglutide. Okay. It's the same as Trulicity, which causes, again, hypoglycemia and pancreatitis. And that's it for type 2 diabetics. Let's go now to insulin. There are 1, 2, 3, 4 types of insulin. So we have rapid acting, short, we have intermediate, and long acting insulin. What you need to know here as a nurse is the onset, peak, and duration. All three has to be known. The reason is onset is when it starts, so therefore you need to give it in relation to a meal. Patient doesn't eat, blood glucose will drop, hypoglycemia sets in. Peak is the time of highest drug action, meaning this is the time when the patient usually goes hypoglycemic. So you need to monitor the patient during that time. The duration will tell you when you can safely give another dose because it's already gone, eliminated by the body at that time. So again, onset, you need to know when do you give it before a meal, meaning do you give rapid acting insulin, and since this says 25.25 hours, so that's 15 minutes, if you don't see the chow cart on the floor, can you safely give it?
Can you repeat your question, Professor?
The chow cart isn't on the unit yet, and it's time for the insulin. Dietary department's late. The meal trays, the chow cart, the meal cart in the hospital hasn't arrived on the floor yet, but it's time to give your aspart. Can you give it?
No.
No. Wait for it.
The meal trays must be on the floor. That way you know, okay, I can give this now, and then 15 minutes later, I'll give him the meal. Plus, it's easier said than done. You have multiple patients. Let's say you have 6 diabetic patients. That'll take time, right? Because you have to check each one's sugar, give each one their insulin, and then give them their meals. Okay, but approximately, about 15 minutes, the patient should eat within 15 minutes of receiving the injection. So we have, I'll test only aspart and lispro. These are the 2 most commonly used. We have Novolog, Humalog. So aspart and lispro. Tests will only use generics. Okay, you won't see brand names on my test. The NCLEX won't use brand names. They only use generic. So, this is a range, so you go with the median. So 1 to 3, that will give you about 2 hours. So 2 hours after giving it, check the patient for hypoglycemia. So question on the test would be, when will you give it? How far from a meal? When would you check them for hypoglycemia? Right? So onset, peak, at least onset and peak should be known. Short acting, there's only one, regular insulin. So all the vial will say it's regular. This is the brand, Humulin. Logs refer to rapid acting, and then lins are regular insulin or short acting insulin. This one has a 30-minute onset, so you can give this half an hour before the meal. So this would be about maybe 2.5 hours after meal, they go hypo. So check them during that time. So because of the short duration, both of rapid and short acting, so these are the two perfect pre-meal insulin. But between the two, rapid acting is preferred for pre-meal, and then for random sugar spikes, let's say, in between the doses, the patient, in between rapid acting doses, the patient gets a random hyperglycemic episode. So you call the doctor, you want something, you need insulin, he'll give you an order for regular. But the usual protocol is to give Novolog, Humalog pre-meal, and regular insulin for random blood sugar spikes. Intermediate insulin doesn't have to be given in relation to a meal. Look at the onset. It's 1.5 hours. As long as you give it at the same time every day, the patient will be fine. Plus, look at the peak duration. It's very long. So the median is about 6 hours, 6 to 8 hours. Right? So let's put it at 8 hours as our median. So after giving this, check the patient. Usually we give this around 9 or 10 a.m. and also 9 or 10 p.m. So given twice a day. So about 8 hours. So we give it at 10. So you watch the patient for hypoglycemia around 6 o'clock. Long acting. We have Glargine, which is Lantus. This is the only true peakless insulin. Peakless meaning no peak, none. Detemir and Degludec, although long-acting, they do have peaks. All right, but you'll be surprised. Most nurses say, no, all of these have no peak. That's not true. Detemir, which is Levemir, and then this is fairly new, Tresiba, which is Degludec, does have a peak also. So they're about 8-9 hours for each one. But look at the duration. This one is steady for 24 hours. This one is ridiculously long, 42 hours. So therefore, this is not given usually daily, or sometimes the patient may get it daily, but look at the duration, 42 hours. So almost 2 days. Okay, so for this reason, if they forget a dose, we really don't make a big deal because the drug's still in the system. That's it. Again, do the onset and peak, duration preferably, but most important are the onset and the peak. Again, onset would be your in relation to a meal, and then peak is very important because this is when your patient could go hypo. Do not mix anything with long-acting insulin. They should be given on their own. You can mix short-acting or rapid-acting with intermediate. That's fine. In fact, that's the composition right here. So Novolin, for instance, 70-30. That means this one contains 70 NPH, 30% regular, right? That's what these combinations mean. I'm not testing you on regimens because we need clinical experience in order to be familiar with insulin regimens. Just to explain one, our body usually produces a constant amount of insulin. We call that the basal insulin, meaning regardless if you're eating or not, the pancreas normally produces a certain amount of insulin. We can also see patients given a basal dose, meaning regardless if the patient eats or not, regardless of the patient's blood glucose level, some patients will receive a basal insulin dose. But that's not everybody, right? But later when you see basal That's what it's referring to. Understand? Meaning the patient, regardless of their blood sugar, gets a basal dose, regardless. And on top of that, if they have a certain blood glucose level, they'll be given another insulin dose on top of the basal dose. Do you understand that part? Meaning to mimic the body's insulin production, some patients receive a basal dose, basal insulin. Do you understand what I'm saying?
Yes.
Okay, so there are two types of insulin regimen here. So a patient can receive basal insulin on top of the mealtime insulin, or most patients just get a mealtime insulin, no basal dose, which is the norm. But you will see some patients, there are only a few of them, they're not the norm. These patients usually are the really resistant patients to insulin, really bad severity of insulin. Those are the ones that get basal dose. I've only seen a few in my practice, maybe no more than a dozen. Okay, there aren't a lot of them receiving that regimen. Okay, there are some factors affecting insulin absorption. Look at this highlighted statement here. Rotation within one anatomical site is preferred to rotation from one area to another to prevent day-to-day variability in absorption. This means that it's better if you exhaust one anatomical area first before you go to another. Meaning, if you're going to give the patient, let's say, insulin 4 times a day, breakfast, lunch, dinner, and at bedtime, you do it on one site. I'm not saying you give it on the same site. I'm just saying you give it on the same anatomical site. So if you started with breakfast in the arm, go to another site on the same arm. Go there for lunch, dinner, bedtime. And then next day again, lunch, dinner, bedtime. Lunch, dinner, bedtime. All right, this is the ideal way. So you put it on the same anatomical site, not like breakfast here, dinner here, lunch here, bedtime here, right? So don't go like that. So go in a organized manner. Okay, so the same anatomical site. Once you've exhausted that site, then you switch to another anatomical site. Complications, there are two. We have Dawn phenomenon and Somoji phenomenon. Dawn is represented here. So dawn is red, Somoji is purple. All right. So if you see the figure, both conditions, whether dawn or Somoji, result in high blood glucose in the morning. So this level is about 210, over 200. Okay, so when they wake up in the morning, they have high blood sugar. Now, the only way to tell them apart is to check the blood sugar at this time. This is about 4 or 5 a.m. See, the blood glucose here are different. So to tell them apart, because their interventions are completely different, you have to know what the patient is having first before you can decide on the treatment. Meaning you need to discover first, is this dawn or is this Somoji phenomenon? So if it's dawn, the blood glucose is around 150 when you check it at 4 or 5 a.m. Whereas if it's Somoji, the sugar is very low. Patient's hypoglycemic at about 4 or 5 a.m. Therefore, the cause here, dawn phenomenon, is caused by this. release of adrenal hormones, which are cortisol, which causes blood glucose to rise, because that's a stress hormone. That's a steroid, corticosteroid. So how to fix this is you give more insulin at the evening dose at 10 p.m., not earlier with dinner, meaning you give it almost around bedtime, but you give a NPH. So therefore, if you give NPH here at bedtime, remember NPH peaks about 8 hours later, right? So if you give it here at bedtime, let's say 10 p.m., by the time it peaks, which is 8 hours later, instead of the sugar going up like this, because you have NPH, the sugar will now go this way. It will now stay within normal. Sumoji, however, is caused by a counter-regulatory response to nighttime hypoglycemia, meaning the patient didn't get enough food to sustain them in the morning. So they ate dinner somewhere here, and then around 6-8 hours later, they ran out of sugar, so their sugar dropped, and then in response to hypoglycemia, patient produces glucagon, undergoes gluconeogenesis, undergoes ketogenesis, sugar goes up by the time morning comes. So to prevent the hypoglycemia, we will give the patient a bedtime snack, managed by giving them a bedtime snack, and then also watching exercise programs which may be causing the hypoglycemia. And that's it. Those are two complications. First thing again is to distinguish first what is the patient having. After that, then you decide with your treatment. I'm not testing, what is this? Insulin pumps, but I'll just give you a quick rundown, a few seconds. So this is the pump. This is the, there's a tiny needle here that gives the patient glucose continuously. And this is the sensor. This is the, no, not this, it has a sensor, but this is the meter. Okay, so this guy here monitors the patient's blood glucose. Both are 7-day things, meaning this will stay on the patient. You don't see it, but there's an adhesive here, and these are all waterproof. So we put them on once a week, and then we change them once a week. So this guy here continuously monitors the glucose and then sends the information wirelessly to the pump. And the pump is programmed to deliver a constant dose of insulin depending on the blood sugar reading. During meal times, however, because the patient will get a bolus amount of sugar, so the patient will also have to enter a certain amount of insulin to be given with the meal. Okay, so the patient here has to be trained with counting calories so that they can do the bolus dose. So as you can see, there's a little bit of learning curve with this. So this is not very popular among the elderly, but active athletes, younger people have these a lot. In fact, some of the students in class may have insulin pumps. I've had a few over the years. They have insulin pumps. The technology is old, but then more advances are using this now, not in the form of a pump, but this technology here, the wireless sensor. So you've seen Dexcom, and there's also Freestyle Libre. So they're using the technology of the wireless meter reading. So it's been around, but they just didn't commercialize it the way they're doing now. Next question on the exam will be insulin storage. Insulin in use may be kept in room temperature so that when you give it, it's not cold. However, all drugs which are not used, all insulin that is not used must be in the refrigerator. The exception is Glargine. Glargine, even when in use, must be stored in the refrigerator. Again, all insulins in use can be put in the room temperature, except Lantus. Lantus, even when used, has to be kept refrigerated. All other insulins not opened yet must be in the refrigerator. And all of them, of course, once opened, must be discarded 28 days, some 30 days, depending on the type. And you should know this already, the insulin size, how to give an insulin. Here's the review, chart 64-3 on how to administer insulin correctly. There is you guys discussed mixing insulin, right? In fundamentals of nursing? Yes?
Yeah.
Okay, so I'll test that again. There'll be one question on mixing insulin.
Cloudy first.
Well, you have to go through the steps of where to put air. Remember, we put air into the vial, right? So remember, you must know where to put the air in first, because we have two vials with
You
one
went first for air.
syringe. On nutrition, I have no question because I'm not a hypocrite. We are not trained nutritionists. We are not diabetic educators. So diabetic educators and dietitians obviously went to school, proper training in order to discuss nutrition. We are RNs. We know nothing about nutrition, right? So the best thing you can do is refer them to the dietitian or the diabetic educator, because those people know what they're doing. They're trained. That's what they do every day. So we'll skip the nutrition part. That's long. All right, exercise. The main thing you need to remember is the effect of exercise. That way you know how to tell the patient regarding exercise. Exercise has the same effect as insulin because exercise makes the muscles more sensitive to insulin. Therefore, what will happen to your insulin needs when you are exercising? Because remember, when you're exercising, you're burning sugar, right? Plus, you're making the cells more receptive to insulin. So therefore, can you say that exercise is insulin?
Yes.
Yeah. Yes, because insulin, exercise is insulin. You know, quote, the effects of exercise is the same as insulin. Because exercise lowers blood sugar. So therefore, exercise is insulin, right? So therefore, what happens to your insulin needs when you are exercising? It decreases. Very good, because exercise is insulin. Exercise has the same effects of insulin. So therefore, it's good. The patient needs less insulin, plus they use more of the sugar, keeps their sugar levels normal. The exercise here, though, must be regular. It must not be out of the blue whenever the patient thinks, oh, it's a good idea to exercise today. Okay, it should be regular. It can both prevent and control diabetes. Adjustment in exercise will have to be made though. So, because again, all you need to remember is exercise is insulin. So when we go to this part right here, 64-4, if you here, look at this. Do not exercise unless the patient's blood glucose is at least 680 and less than 250. So here, if the sugar is already less than 80 and then you exercise, remember, exercise is insulin. What will happen to the blood glucose when you exercise? and it's
Decrease.
than 80. Yes, it will drop below 80. And now next thing you know, it's already below 60 or 60. So you're hypoglycemic now. What about if it's over 250? Remember the drawing I did earlier when we got to 250? Remember when I was drawing the poor, illustration of the glucose and, the cells were hungry. You remember that illustration?
Yeah.
Um, right here. Can you see it?
Yep.
All right. So remember when I said that when you reach 250, what's happening to the patient? How did we get to 250? What was the patient doing? Patient
Protein.
breaking, right? Their patient's already breaking down fats and protein. That's how we got to this sugar level right here. So these events are already occurring. The fat and the protein breakdown is already occurring. That's why the patient reached 250. Now imagine if you exercise at this point. Can exercise still drop the sugar if this is already in motion? Because remember, this thing here, once started, becomes a vicious cycle. You cannot stop this unless you give insulin. The only intervention to stop this cycle of events here is to give insulin. Once insulin's here, stops all that sugar from being there, glucose enters the cell, no more of these, no more of these. Because once again, once these are set in motion, it will not stop. The sugar will only go up or higher and higher. Okay, there will be no ending here unless you stop the cycle by giving insulin, which started the whole thing in the first place. So therefore, that's why it says here, do not exercise unless your sugar is less than 250 and of course over 80. Does that make sense? And of course, the others are, self-explanatory. Of course, you carry a sugar source when exercising, just in case your glucose drops during exercise.
Professor, so if these patients or these people exercise regularly, do they have to plan when they take their insulin with their
Yeah.
exercise or no?
Yeah, definitely. There will have to be adjustments made because exercise will, I think it was mentioned earlier, there has to be adjustments made if the patient begins an exercise regimen.
Okay.
So the insulin must be adjusted because remember, again, exercise is insulin. There has to be changes to be made. The usual dose of insulin has to be lowered because otherwise you have hypoglycemia. Under gastroparesis, it was mentioned that the next statement after that one, I think that's where the question about exercise leading to hypoglycemia.
Professor, you're cutting out.
That's okay. You didn't miss much. Okay. This for me, Miss Press. The highlighted section.
Which one? Me?
Highlighted section.
Okay. There is confusion about whether to give or to hold insulin from a patient who is NPO. Administration of rapid-acting or short-acting insulin, as well as amylin and incretin mimetics, will cause hypoglycemia if a patient is not eating. Basal insulin should be administered when the patient is NPO because it controls baseline glucose levels. Insulin mixtures are not administered because they contain some short-acting or rapid-acting insulin and will cause hypoglycemia.
All right. Thank you very much. So this is the rule for NPO patients in the hospital. So we have plenty of diabetics. Most of them will be NPO. So no insulin if they're NPO. No rapid or short-acting insulin. However, if they are ordered basal insulin, the basal insulin continues to be given even if they're NPO. Does that make sense? And I already explained to you guys what basal insulin is. Okay, so this is again the insulin given regardless of their blood sugar reading. Surgery will skip. This is surgical management diabetes, meaning this is a pancreatic transplant. How many people have you heard which people who cure diabetes because of pancreatic transplant? I heard it. No, I heard of billionaires dying still that with all their billions because of even with surgery. So we'll skip all that. It's not. Let's go to care will be simple. Again, if you compare this to chapter 6 in peripheral artery disease, foot care is the same thing. So foot lotion, but not between the toes. Okay? So put lotion on your feet, but not between the toes. To keep those areas dry. The area between toes must be dry, so no lotion. Shoe size over here should be half to 5 inches longer than the longest toe. That would be most common. That way you get any blisters or wounds. Don't wear the same pair of shoes 2 days in a row. Let the other shoe dry first before you wear them again. Check it. Just in the patients, especially patients have neuropathy. What am I doing? This is the same thing as in chapter 6. They do need professional help. These here, Mr. Source, for instance, for toenail care. They have untitled chapters as we care. So a wound is found on the foot or the feet. They should be monitored if they get infected. So they deal with their last is hypoglycemia. Symptoms first. Table 64 gives you the most common signs and symptoms. Now, if you notice, they all start with neuro because the brain is the largest consumer of glucose. The brain eats 25% of our glucose. So it's only right that the first symptoms will be from the brain. You can look at this, they're all related to the brain. They're neuroglycemic symptoms. On column 2, they're neurogenic. These are referring to the adrenal symptoms. Is hypoglycemia life-threatening?
Yes.
Yeah.
Will it trigger fight or flight?
Yes.
Yeah.
Yes. So epinephrine will be produced, resulting in increased heart rate and vasoconstriction. That's why the patient will be sweaty, cold and sweaty, and have palpitations when they are hypoglycemic. And here's a warning. We just concluded hypertension and beta blockers. Of course, the proper name of beta blockers is beta adrenergic blockers. So that they block the epinephrine, norepinephrine. So therefore, with a patient taking beta blockers, will they have the symptoms here if they're taking beta blockers?
No.
No. So that can be dangerous because sometimes that could be the only thing the patient is aware of. So if you take that away, look at this. If a patient's confused, do they know that their sugar is low?
Yes.
Yeah.
No, they're confused. No, they're confused. I mean, are you aware that you're confused?
Nope.
No, people think
No. Yeah, 'cause it's not the same as taking a test. You know, I'm confused with this. You're not really confused. All right, because true confusion is you're not aware of that you're confused. All right, here's a side-by-side comparison of hypo and hyper. So start from this. Dehydration, of course, only hyperglycemia has dehydration. These are your respiratory systems. Both will have manifest changes. We have a big difference also in the ketones. So no ketones, ketones in hyper. Glucose, obviously, this one's below normal, this one's over 250. What doesn't mean 111 is not hyperglycemia. Okay, this is just saying definitely hyperglycemic 250. Let's go to the management. So once you identify these causes, you have a list here. Different causes of hypoglycemia. So we have gastroparesis here. We have exercise. What's exercise? Right here, regular exercise weight loss. Eat enough or took too much insulin. Here, drank alcohol or too much alcohol. That's 7 is the last type. This is now your management for hypoglycemia. Take note that the title is at home. We have 3 levels of hypoglycemia: mild, moderate, and severe. Mild is considered is less than 60 but over 40. Moderate is less than 40, less than 40 but over 20. And severe, of course, is less than 20. Now, in my experience, hypoglycemia is tolerated differently by patients. I've seen somebody with a sugar of 20 who was walking around. I saw somebody with a sugar of 62 already unconscious. So that's what I mean by people present differently for hypoglycemia. So use your common sense when following this chart. Meaning, if the sugar is, let's say, 59, but the patient's unconscious, are you proceed? Are you going to shove it down the patient's throat? Or if your patient's still awake and is able to eat, do you have to give them glucagon injection?
No.
Not necessarily. All right. So this is what I mean by use common sense when you use the chart. Drought is only IM or sub. It can't be given IV or any other. Remember, is all the interventions listed here, from the food, the snacks, to the injection of glucagon or giving IV dextrose if we're in a hospital, are temporary fixes. They do not fix hypoglycemia. What's the only fix for hypoglycemia? How do you fix it?
Sugar.
You give them a meal, right? You eat. That's the only cure. Your sugar is low, go eat. So therefore, after giving your interventions there, what should it be followed with?
Reassessment.
A meal. You give them a meal so that we get rid of the hypoglycemia altogether. Not too much though, because now you'll have hyperglycemia. But that's where your insulin comes in. All right. For drug therapy, we have side effects here. Glucagon causes vomiting. So after giving it, remember the patient is unconscious usually when we give glucagon. So what should you do? after giving it, because there's a danger of vomiting.
Lay them on their side, maybe.
Right, aspiration precaution, so don't forget that. So after giving it, make sure elevate the head of the bed, put their head to the side, just in case there's nausea. And once they're no longer nauseated, like I said, give them a meal. A glucagon does not fix hypoglycemia. It's a temporary fix. So you need a meal in order to treat it for good until the next hypoglycemic episode occurs. So who wants to, the prevention strategies, of course, if you look at the bullets earlier listed from too much insulin, blah, 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 gastroparesis, these are the interventions here, which are self-explanatory, meaning you know those are the causes, then of course you know which ones to eliminate to prevent hypoglycemia. Hypoglycemia is fatal. It's dangerous if the patient's alone. Remember confusion? Once confusion sets in, the patient will be unable to make good judgments. So the hypoglycemia gets worse. There's nobody around to help them. They're screwed. Here's the warning on beta blockers, which we discussed already earlier. And that's about it. That's the end of hypoglycemia. If questions arise about the blueprint, you know how to contact me, email, or send me a text message.